To everybody, my name's Kathy and I've got a background in nursing and I'm here to talk to you today about cardiac rehab in the bush. So I bet you didn't know you were going to be here for a cardiac rehab talk, but you hopefully will appreciate the relevance of cardiac rehab and particularly the aspects about it that I want to talk to you today about. Okay, the area that I'm representing is far north Queensland. I'm actually from Cairns and we provide services for this whole sector here, which I just call the pointy end of Queensland for various reasons, not just all geographic. Okay, an overview of what the presentation will go through, just a bit of background. Why is there a need to provide cardiac rehab out bush? What's required in developing a program, implementing a program, sustaining a program? How is that relevant to the management of rheumatic heart disease? And some of the things that we need to consider following valve surgery, and the lessons learned from a project that I was working on that I'll talk to you about. What's the big deal about cardiac rehab? Well, cardiac rehab programs are ideally positioned to provide comprehensive cardiovascular disease risk reduction services. The clinical benefits of cardiac rehab have been demonstrated. This was done through a Cochrane review and a multitude of other studies that fed into that. Excuse me, I think the Alice Springs air is getting to my throat. Cardiac rehab actually results in decreased mortality and improved quality of life. Once upon a time, clinicians used to think, oh, but it just makes people feel better. Well, it actually does result in decreased mortality, so it's worthwhile. However, what's the participation rate? In Victoria, it's only about 22% of eligible people actually participate. In Queensland, a little bit better, in that it's about a third of those eligible people participate. However, for Aboriginal and Torres Strait Islander peoples, the participation rate is only about 3% at best. What is cardiac rehab? Well, it's the process through which cardiac patients return to an active and satisfying life, aimed at preventing recurrence of further cardiac events. A typical model of cardiac rehab actually involves clients and their partners attending a group-based session, usually at a facility. It tends to be at a hospital, sometimes it's in a community health centre. It's held 1 to 2 days a week, a group-based session over a period of 6 to 8 weeks, and usually facilitated by a cardiac rehabilitation coordinator. The World Health Organisation and Heart Foundation of Australia recommend that all eligible people are referred to cardiac rehab and should attend cardiac rehab. The reason for that being that cardiac rehab is effective. It results in a 26% reduction in cardiac-related mortality for those people who actually participate and complete cardiac rehab compared to those eligible people who don't. So it's fairly effective. But it's not quite as sexy as angiography and bypass, and so we have to really keep driving that home. It's really effective. What is it? Fun physical activity. It involves discussion groups. It should definitely involve the family. So why do we need it out bush? Well, we know cardiac rehab is part of cardiac care. However, we also know that there are barriers to access and participation for Aboriginal and Torres Strait Islander people. We've tried to enhance the typical programs. We've tried to bring in health workers. We've tried to make them more culturally appropriate. We've tried to do all sorts of things, and that's been somewhat effective, and it hasn't been too bad. But not as effective as what we'd like. So clearly there's a need to actually take the program to where the people are, take it out to the Indigenous community, and that can be either in the bush or in the urban centre, because we know that even in an urban centre it doesn't necessarily mean that the Aboriginal and Torres Strait Islander people are actually engaged with the health service, so we need to take it to where they actually are. I've been working on a project called the CRIC project, which is the Cardiac Rehab for Indigenous Communities. The purpose of this was to increase the uptake of Indigenous people into cardiac rehabilitation. And there's been some lessons learnt that I'd like to step you through along the way, but I am aware of the audience that I'm talking to. Most of you probably have got a fairly good sense of really what's required to set up a program. However, there still could be some take-home messages that I hope to leave you with anyway. First and foremost, in setting up or developing a program, the first thing that should happen is support. You need to obtain the support of the actual Indigenous community. Behind the eight ball altogether if you don't do that. And a good way of doing that, and what the project actually found and utilised, was providing information about what are the rates of the heart disease, what are the rates of participation like in that particular facility or district or region, because it can vary from different regions, so make it actually specific to the group that you're actually talking to. Deliver the information in a really meaningful way. Case studies and scenarios are a really good way of getting the message across and getting people to actually understand what the value of it actually is. Data is good, but also the way that's actually put across is as important. Need to deliver the information to the right people if you're wanting to set something up at a health facility, and that the leaders in the primary health care facility are the right people. And if a service or a program is to be developed in a primary healthcare centre where they haven't necessarily got the capacity just to run it all themselves, then we need to collaborate with other clinicians, other service providers in order to develop some solutions and to work through some of the barriers and issues. The objective of the CRIC project is to actually pilot a training program for clinicians working in Indigenous communities in the Cairns, Cape York Peninsula and Torres Strait regions. Cairns is here, TI is here. I haven't done the trip by sea or road, but I have done it by plane. And a Qantas jet still takes 2 hours to get to Horn Island. To get to the centre of the Cape is a 2-hour light plane craft. There are 3 phases of the project. The first one, the important one, the long lead-in time, was used for consultation and engagement of the nominated Indigenous community site. We didn't really have any funding, we had some funding for the project, but not to actually give to the site. So the sites that were selected were they were approached, asked if they felt that they had any capacity at all, if they wanted to deliver this sort of service and so on. And that's who we ran with. To develop and deliver a training program, and then after the delivery to actually go back and actually evaluate, did anything result. There were 4 pilot sites. Two of them were community controlled primary healthcare centres, one in an urban area, one in an isolated area, and 2 state health run facilities, one in the Torres Strait and one in the Cape. The participants for the training were multidisciplinary participants. We actually asked each site to identify who they considered would be a really good team. We really strongly encouraged the team approach. That was not just an idea, but the actual literature shows that the best way to deliver programs in the Indigenous community is through using a team approach. So they identified health worker, registered nurse, allied health and medical officer. The content of the training was not so much what people tended to anticipate, that perhaps they were going to get all of this clinical information, but a lot of the focus was actually on the process. How are you going to identify who your group is? Who's going to do that identification? What's your referral pathway going to be? Who's going to make the referral, receive the referral, process the referral? Who's responsible for doing that? By the way, you probably should deliver some kind of a program. What capacity have you got? What sort of staff have you got that could deliver something? We'll work that out later. And some information about some clinical content. The training program actually was delivered in 2 phases. There was phase 1 of the workshop, which was foundation, because a lot of people in these sites themselves, the clinicians themselves, hadn't actually been to the referral hospital. They didn't quite know what the emergency department was like, what the cardiac investigations department was like, how does someone that they send in from the community actually get processed, managed, what are some of the investigations they have. So we walked them through. It was went over 2 days. There was some, we had guest speakers come in, we gave them information about heart failure, we gave them information about rheumatic heart disease and so on, medications, you name it. They got the standard thing that you'd probably expect. But the thing that the clinicians all liked the best was having the walk around the hospital, going through their different cardiac investigations themselves and getting a sense of what it was that their clients would actually be involved in. And the second part of the workshop was actually going back to the workplace sometime later and actually working with that same group of people to help facilitate how they could implement some of that knowledge. So there's the information, how is it going to be applied? Not rocket science, not difficult, but very effective. Just a little bit about this is more or less what I've said before. The workshops, there was foundation workshop, which was held at the hospital because that's where people get sent into, and then implementation workshop was held back out at the site. All in all, there were 7 workshops. Each one was different, and there were 20 participants. The evaluation phase of the CRIC project was really looking at what happened as a result. What's come to pass is that each site has actually identified different needs. It's not surprising. The training was only really one aspect of this. Most sites actually wanted extra resources, and all sites needed an enormous amount of support. A lot of contact time with the project officer, a lot of facilitation, and I have to say that with the resources, it varied what kind of resources they actually wanted. It could have been